The first speaker is Dr. Bappaditya Kumar. He will be speaking on valvular heart disease, the recent guidelines. Bappa.
দেখা যাচ্ছে তো? ঠিক আছে। Good morning, my respected seniors and dear colleagues. So over the next few minutes, I will be discussing on the recent 2 guidelines on management of valvular heart disease. So I would like to keep it simple and to the point. So I will be discussing based on the 2021 ESC guideline and the 2020 ACC-HA guideline. So I have divided my talk into few subheadings. The first one is the anticoagulation in AF in patients of valvular heart disease. So I would just like to stress the new things that have been proposed by these guidelines. Now, the ACC-HA guideline states that for patients with valvular heart disease and AF, if the patient has a rheumatic MS, you go for a long-term VK anticoagulation. For patients with native valve disease, except rheumatic MS, you calculate the CHA2DS2-VASc score and go for a NOAC or VK based on the CHA2DS2-VASc score. For patients with a bioprosthetic valve, for the first 3 months, if he has a new onset AF, you go for anticoagulation with a VK. After 3 months, you go for a NOAC or VK based on CHA2DS2-VASc score if the patient has AFib. For patients with mechanical heart valves, you go for a long-term anticoagulation with VK. But nowhere they have recommended that the patients for where we are selecting a NOAC or VK to choose a NOAC in preference to a VK as per the ACC-HA guideline. On the other hand, the ESC guideline recommends that for stroke prevention in AF patients who are eligible for a oral anticoagulant, NOACs are recommended in preference to the VKs in patients with aortic stenosis, aortic and mitral regurgitation. The use of NOAC in patients with AF and moderate to severe mitral stenosis is contraindicated. But the ESC guideline, like the previous guideline, has remained silent once again in patients with mild MS. Now, patients with aortic valve disease. This is the most important thing, as Soumitra sir was telling. So this is where most of the controversies happen, but I would like to keep it simple. So patients with AS can be divided into 4 groups. The stage A, who are in risk of developing AS, that is the aortic sclerosis patients. We have kept this from the out of this discussion. The next group is the mild to moderate AS, where the Vmax is less than 3.9 meter per second. These patients only require intervention by a SAVR if the patient is undergoing any other cardiac surgery. For patients in this group, if he is not going any other cardiac surgery, we will just observe the patients. Now coming to the next group, that is stage C, where the Vmax is more than 4 meter per second. So there are 2 groups of patients, C1 and C2. In C1, the EF is more than 50%. In C2, the EF is less than 50%. So for patients with severe AS who are asymptomatic, that is the stage C patients, if the EF is less than 50%, you directly go for a aortic valve replacement, either by a SAVR or TAVI. I would come regarding the choice of these valves in the next slide. In these patients who are asymptomatic, if it requires any other cardiac surgery, you go for a SAVR or TAVI. For other patients where the EF is more than 50%, the Vmax is more than 4 meter per second, but the patient is asymptomatic. In those patients, if the Vmax is more than 5, if the BNP is more than 3 times the level of normal, if there is rapid progression of disease, that is the Vmax increases by 0.3 meter per second every year, or on exercise tolerance test, there is decrease in systolic blood pressure by 10 millimeter mercury. In those patients only, you go for aortic valve replacement, and here the indication is only a SAVR. So we are not going for a TAVI in patients with asymptomatic severe AS. Now the patients where the patient is symptomatic, these patients can be categorized into 3 groups. D1, that is the patients where the Vmax is more than 4 meter per second and the patient is symptomatic, or D2 and D3. In D2, the Vmax is less than 4, but the EF is also less than 50%. On dobutamine stress echo, we will get a Vmax more than 4. And the stage D3, where EF is more than 50%, but the patient is having a low flow, low gradient AS. Here we can confirm our diagnosis by measurement of the stroke volume index, which is less than 35 milliliter per meter square. So these are basically the 3 categories of symptomatic AS patients, and all these patients require aortic valve replacement, either by a SAVR or TAVI. Now, in the next slide, I will come to the indications of SAVR and TAVI. So this is a busy slide, but I would make it very simple. A patient with AS who has the indication of AVR, class 1 recommendation, there will be a shared decision making for the heart valve team and the patient regarding the choice between a SAVR and TAVI. Next, calculate the risk. If the patient has a high prohibitive surgical risk, SAVR is contraindicated. In these patients where the valve and vascular morphology is favorable for TAVI and life expectancy and quality of life and accepted quality of life is more than 1 year, in these patients only we will go for a TAVI. So a symptomatic severe AS patient where there is indication of AVR, high surgical prohibitive risk, in those patients where a life expectancy and quality of life, accepted quality of life is more than 1 year and valve and vascular morphology favorable for TAVI, you go for a TAVI class 1 indication. For all other patients where the estimated surgical risk is not high, we will have to select between a TAVI or a SAVR. There will be some patients where VK anticoagulation is contraindicated. In those patients, we will choose a bioprosthetic valve. So bioprosthetic valve can be done either by a SAVR or TAVI. In patients where BK anticoagulation is okay, in those patients where there is an indication of AVR, if the age of the patient is less than 50 years, directly go for a mechanical aortic valve replacement. There is no question of bioprosthetic valve, no question of TAVI unless and until there are other indications. For other patients where the age is more than 50 years, here we will select between a SAVR or TAVI. A simple thing, a symptomatic severe AS that is stage D1, D2, D3, or a asymptomatic severe AS where the EF is less than 50%, in those patients only we will select between a SAVR or TAVI. In all other patients, we directly go for a SAVR. That is asymptomatic severe AS patients where the EF is more than 50%, we are undergoing a AVR. For any other indication, as I have already discussed, decrease in BP on exercise tolerance testing, Vmax more than 5, rest, BNP or rapid progression, all these patients will undergo a SAVR. In the symptomatic patients with AS, that is stage D1, D2, D3, and asymptomatic severe AS with less than 50% EF, here only we will decide between a SAVR or TAVI. If the age is less than 65 years, directly go for SAVR. If the age is more than 80 years, TAVI gets a better recommendation than SAVR. In the intermediate age group, we'll have to select between a SAVR and TAVI based on the heart team evaluation and the patient preference. Hope I have been able to make clear the indications of the ACC-AHA. Now coming to the ESC guideline, they have been more or less similar to the ACC-AHA guideline. I do not require to discuss this thing in detail, but I would like to stress one important thing here. In patients that is stage D2 and D3, that is patient with low flow, low gradient AS with normal EF and low flow, low gradient ES with reduced EF, in those patients, they have advised to go for a coronary CT to look for the aortic valve calcification. So as Soumitra sir was telling, in all these things, the indication wise, you do not need to look for the AVA, aortic valve area. You can do this based on these gradients, based on these symptoms. Now, this is the recommendation of the ESC guideline. They have kept it more or less simple. For patients where there is an indication for AVR, the indication of AVR is same between these two guidelines. They recommend that for patients where the age is less than 75 years and a low risk for SAVR, where the STS score or the Euro score is less than 4%, you go for a SAVR. For patients more than 75 years or a high surgical risk of more than 8% by the STS score, you go for a TAVI. For other patients, a heart team evaluation and the patient preference for SAVI or TAVI. So this was the most interesting and the most difficult thing in my entire presentation. I have tried to keep it simple. Next, coming to the AR, the management of AR in surgical management of AR or the indication for management of.
Yes, sir. Just 1 second. Shantanuda, I think as all the subjects are totally different, not connected with each other, better to have a brief discussion. Otherwise, we'll confuse everything together.
It's extremely difficult to maintain the timing, Soumitra.
Yeah, but you have to be brief in our discussion. I'll request, because otherwise you'll totally forget the AS when you will talk about MR later on. So just with your permission, Bappa, go back to the anticoagulation first quickly, because it's very difficult to.
Yeah.
Go back to now here. Now you see the bioprosthetic valve
Yeah.
On the right, new onset AF within 3 months of valve implantation.
Yeah.
Anticoagulation with VKA.
Yes, sir.
So first 3 months, they are not talking about NOAC.
No, for first 3 months, they are not talking about NOAC. And this guideline is more or less similar between the ACC and the ESC guideline.
And if in bioprosthetic valve there is no AF, after 3 months, do you need any OAC?
Now, after 3 months, we do not require any OAC. There is a minute difference between the two guidelines. The ACC-HA guideline recommends for a bioprosthetic valve to go for an antiplatelet, single antiplatelet agent, whereas the ESC guideline does not recommend any antiplatelet after 3 months.
One more, I think there is a wrong arrow over here. If you see the bioprosthetic valve on your left side, more than 3 months, it should be less than 3 months.
No, sir. This is more than 3 months after procedure. NOAC or VK based on CHADVA score. If the bioprosthetic valve patient requires any anticoagulant for AFib, the patient
with
has
AF, with AF, okay. And if there is no AF,
you do not require any anticoagulation.
Soumitra, that is a little debate here, because all of us throughout our career we gave anticoagulants to these groups of patients on bioprosthetic valves for the first 3 months, and that was with VK. It is said that the sutures and other things, that there will be thrombus deposition on that. So allow them to endothelialize. Once that takes up to 3 months. After that, you don't require any anticoagulant.
Even in sinus rhythm,
in sinus rhythm, whatever I'm talking about,
absolutely,
in sinus rhythm.
Absolutely.
So,
and one more thing, if that bioprosthetic in mitral position may not be as innocuous as bioprosthetic in aortic position.
It is similar if the patient is in sinus rhythm.
Yes.
Your protocol is absolutely same.
No. Okay. There is slight difference. In aortic valve, if it is bioprosthesis, and if the patient does not have any atrial fibrillation, then for 3 months anticoagulants, and after that only aspirin or antiplatelet. You don't
Even aspirin is not given.
Yeah, there is some difference. But just a minute. But in case of mitral stenosis, if the mitral valve stenosis is moderate to severe, even the patient is in sinus rhythm, the patient requests anticoagulation for the.
Anjanda, what I am talking about is after the valve replacement with the bioprosthetic valve. I am not taking
bioprosthesis indication for anticoagulation or antiplatelet is same for mitral or aortic.
That's what I'm telling.
That's what Dr. was telling.
First 3 months, you have to give it. And that is VK. That is not NOAC. But after 3 months, it is your option. Most of the Europeans, they recommended NOAC.
Sir, may I comment something?
Yeah.
Yes.
Yeah. These are I have brought from the ESC guideline. The ESC guideline recommends for a oral anticoagulant for first 3 months for a bioprosthetic valve. But this is not the same recommendation by the ACC-HA guideline. ACC-HA guideline recommends to, if only he develops the AFib, then only give for a oral anticoagulant for the first 3 months.
I am talking about the ESC guideline.
So this is the ESC guideline where they recommend to give a oral anticoagulant for the first 3 months.
First 3 months, and that is for both aortic as well as mitral.
Yes.
Whether the patient is in AFib, whether the patient is in sinus.
For TAVR and for MVR, TVR, if it is a bioprosthetic valve, you give a oral anticoagulant for first 3 months.
Yeah.
Okay, fine.
And all along, we discussed in our curriculum, in your DM curriculum, we discussed this ESC guideline basically.
Yes, sir. Yes, sir.
So that has been imprinted in the mind that first 3 months anticoagulants, irrespective of what valve we use, irrespective of if there is an AF. But after 3 months, that is an advantage of bioprosthetic valve that you can go ahead with NOAC.
In AIMS, I spoke to many people for some years ago. They have stopped using any oral anticoagulation after bioprosthesis. Just they discharge the patient on aspirin.
Sir, this is basically they are following the ACC-HA guideline.
They are following the American guideline. Yeah. That, we actually, most of our surgeons here, they followed the European protocol.
Yeah.
British protocol. And so we grew up with that, and that has been imprinted in our mind. And perhaps we didn't do any harm to the patient, rather we benefited.
For bioprosthetic valve, if there is no atrial fibrillation,
then oral anticoagulation could be stopped after 3 months. We don't need to continue them.
Exactly.
That's what it's told. Yes.
Exactly. Shubhro, exactly that is being said.
But whether it needed for first 3 months, that is the
difference between the two guidelines,
okay.
American and European.
Right.
Bappa.
Yes, sir. So, sir, I have discussed this regarding this aortic valve. So, if there is any discussion, we can go ahead with the discussion.
Show me through anything you want to ask?
Yeah, only you said there is no role of AVA. There is only one box where I can see the AVA.
Yes, sir, that is to differentiate between a pseudo-severe AS and severe AS where the EF is less than 50%.
Yes, yes. That is the only one area where you still need to have the aortic valve area.
But for other aspects, we do not require the measurement.
Absolutely, absolutely.
What should be the situation where we should do routine coronary angiography in severe aortic stenosis or severe AR?
So in all patients more than 40 years, we will do a routine coronary angiogram.
Okay.
Here is one query.
Well, those who are below 40?
For below 40, if the risk of CAD is low, we can do a CT coronary angiogram.
So what is the criteria?
Always before going for AVR.
There should be some criteria. As for example, they say if the aortic regurgitation is very high, if the patient's ascending aorta, arch of aorta is dilated more than the certain figure, these are the situations where coronary angiography should be done routinely, irrespective of the patient's age and symptom.
Yes, sir. I have a slide for this in the latter part of my presentation.
Okay.
Antonu, just one query. What is your opinion? No AS symptom. Stage B, 3 means 36 millimeter mercury maximum pressure, isn't it? If you are going for CABG on this patient, no AS symptom, 40 millimeter mercury peak pressure gradient, will you do a surgical aortic valve replacement?
One dictate is if you are opening the chest, if it is for a CABG, you may not. But if you are doing an open heart surgery due to any reason, even if you are doing the CABG on palm, I think it is better to go ahead with the AVR.
Yeah, because it's always difficult to open the chest twice.
Okay.
So may I go forward or there are any questions?
We'll discuss later on.
Go on.
Yes, sir. So coming to the management of patients with aortic regurgitation. So a patient with aortic regurgitation, we have to classify whether he is having a severe AR or moderate AR. I am not going to details of this severe and moderate AR. Just I would like to stress some important things. So a patient with severe AR with symptomatic needs the AVR. Asymptomatic patient with severe AR will require a AVR if the EF is less than 55%, if the patient is undergoing any other cardiac surgery, or the LVEF is more than 55%, but the LVESD is more than 50 millimeter, or indexed LVESD is more than 25 millimeter per meter square. In those patients, we will have to go for AVR. In other patients where there is gradual decline in the LVEF to 55 to 60% over a period of evaluation over 3 studies, or the LV end diastolic diameter is more than 65 millimeter, there is class 2B recommendation for aortic valve replacement. In patients with moderate AR who are undergoing other cardiac surgery, like the patients with moderate AS, even if the patient is asymptomatic, it is the class 2A indication for aortic valve replacement. Now coming to the ESC guideline, this is more or less absolutely similar to the ACC-HA guideline. They have stated the same things. Severe aortic regurgitation, symptomatic, go for surgery. Patient is asymptomatic. This is the same as the ACC-HA guideline. LVEF less than 50% or LVESD is more than 50 millimeter. Only difference is that the ACC-HA guideline recommends that the LVEF less than 55% to go for AVR. The ESC recommends that the LVEF is less than 50% to go for AVR. This is the difference between the ACC and the AHA guideline regarding management of patients with aortic regurgitation. So may I go on? Okay. Now coming to management of patients with bicuspid aortic valve. So this is the most important slide regarding these patients with bicuspid aortic valve. So if a patient with bicuspid aortic valve has a indication, surgical indication of AVR, and aortic sinus or ascending aortic diameter is more than 4.5 centimeter, you go for AVR with replacement of aortic sinus and or ascending aorta at a comprehensive valve center. On the other hand, in patients with bicuspid aortic valve where there is no indication of surgical AVR, if the aortic sinus or ascending aortic diameter is more than 5.5 centimeter, you go for replacement of aortic sinus and ascending aorta. In patients where the aortic sinus and ascending aortic diameter is between 5 to 5.5 without risk factors for dissection, it can be done if it is performed at a low risk patients at a comprehensive valve center. In patients with aortic sinus diameter is between 5 and 5.5 centimeters with risk factors for dissection, in those patients, we will need to replace the aortic sinus and ascending aortic aorta. In patients where there is no indication for aortic valve replacement, valve sparing surgery to be considered at this comprehensive valve center. This is in baseline the management of patients with bicuspid aortic valve. So before I go to the mitral valve disease, if there are any discussions regarding this aortic valve disease management, so we can have it. Okay. Then I am going to. Yes, sir.
Soumitra, Ranjan, any question?
Yeah,
Not really.
The indications are very difficult to arrive at on a particular patient-wise analysis. If you look at the individual analysis, by and large, what is important is that so far as aortic stenosis is concerned, that we must be evaluating the symptoms very carefully and very in details. And the symptomatic aortic valve disease patients, either AS or AR, just to sum up, they require surgical interventions. Whether it would go for aortic valve replacement along with the ascending aorta dilatations part, or it could be selective aortic valve replacement or aortic valve surgery, or whether it is a TAVI or surgical intervention, it all depends on the patient's clinical condition. Because aortic valve disease is itself have a very poor outcome if the severity of stenosis is very high. So aortic valve disease should be looked into in a from different outlook, and we must take into consideration the pros and cons so far as TAVI and surgery is concerned.
I've got one small comment. When you get a bicuspid aortic valve, do you routinely look for other associated cardiac and non-cardiac anomalies, congenital anomalies?
One congenital anomaly is quite common is coarctation of aorta and dilatation of the ascending arch of aorta.
So does that complete the list, or Shantanu, the one to see some others?
There are several others,
including
you need an MRI, brain and other things. But perhaps we clinicians don't look at everything.
Okay.
We look at the cardiac part and leave aside the other things.
Okay, good.
A question was asked. I mean, I just couldn't answer it properly at that time. Shubhro or Soumitra, one of you asked me whether if you are going to do a bypass, a CABG, moderate aortic stenosis,
40 millimeter mercury pressure gradient peak.
are you going to change the valve? One needs
and
to
patient is asymptomatic.
Yeah, so for the aortic stenosis is concerned, this is a bystander, you can say.
Yeah.
It is a bystander, but it is a moderate severity. The textbook description is what I say, that if a moderately damaged valve is there, which in itself does not require management at that point of time, but is likely to require it in near future, you better replace that valve, or you better treat that valve. Here, a likely to have this thing in near future, that means for aortic stenosis, in patients with moderate to severe aortic stenosis, usually there is a progression, and the rate of progression is usually known. That is around 0.3 meters per year it increases. Am I correct?
Yes, sir.
Square.
Bappa?
Yes, sir.
ওই progressionটা কত রে?
0.3 meter per second এর বেশি হলে আমরা significant progression বলি। 0.3 meter per second.
Exactly. 0.3, that's what I said. 0.3 meters per second. If that is we say this is rather an enhanced progression.
Yes.
0.2 is an average progression. So if you can assess that thing, that in next 5 years, the patient is developing another 1 meter. Now it is say 3.5 meters. It will be 4.5 meters after 1 year, after 5 years. It is better to change the valve. That means they have considered the expected progression of the disease, and the disease should be at least a moderate severity. In that case, you can replace the valve. But that is never a class 1 indication.
You see in your government hospitals more patients. Say patient is around 35-40 millimeter mercury maximum pressure gradient aortic stenosis, and there is no indication for anything else, and you are going on seeing the patient. Patient is asymptomatic. Do you really think they require surgery in 3 to 4 years time? I have seen umpteen number of patients that are going on 10 years, 15 years, not progressing.
Definitely.
From 40 to 50, then again 45, then 55.
I agree with your observation. That's why if it is below 40, if the gradient is below 40, a peak gradient I'm not talking about the mean.
Yeah, peak gradient, yes.
If it is below 40, hardly it requires it, because it takes...
Yeah, I am not convinced they progress that
rapidly. It will take minimum 10 to 15 years to reach a severe stenosis.
So,
if
Bappa,
you consider 0.2%.
If the patient is not severely symptomatic, what are the figures for median or peak pressure gradient of aortic stenosis?
Severely symptomatic patient?
Not symptomatic. What should be the cutoff figure of PPG? That means peak pressure gradient and median pressure gradient. What should be the cutoff figure?
Sir, the mean pressure gradient is 20 to 40, and the peak gradient is between 3 and 3.9 for more stage B patients.
It comes to minimum. What should be the minimum peak pressure gradient beyond which you should...
I am telling you, Anjanda, just quiet. When the patient is asymptomatic and there is no other indication for cardiac surgery, yours is 64 millimeter mercury. That means 4 square centimeter.
4 peak gradient.
4 square centimeter. That means 4 into 4 mane 64. And if it is 3 to 4, that means 36 to 64. Yes. There you intervene asymptomatic patient only when you are doing other cardiac surgery. I have got problem with this segment only.
Yeah, that is exactly
on the lower range, 40, 45, and patient is asymptomatic, totally asymptomatic.
Could I say something?
These patients should be individualized. There is no... This is not a class 1 indication.
Absolutely.
Suppose if a guy is having a gradient of say 56, in that case, perhaps you will be tempted to do it. Rather, a patient having a gradient of 38, you will be tempted not to do it. So you need to individualize the patients and they take a...
That is class 2B actually. That is class 2B, isn't it, Bappaditto?
Yes, class 2B indication.
2B.
Yeah, Santanu, suppose the patient has a median gradient of 40, median.
Exactly.
And a history of syncope. There is no effort intolerance.
Shubhro bolbe.
Bolbo. Acha. Judy, what Dr. Go said, like the traditional teaching had been, if the patient has moderate aortic stenosis and you are going to do a CABG, then better get them done because the surgeons wouldn't like to operate it 1 second and open the chest. But now that we have the TAVR available, do you think that this may get modified later? I mean, as TAVR is getting more and more popular, because in that case, you don't have to open the chest later.
Shubhro, already it is 2B recommendation, which is very, very weak recommendation.
It is weak recommendation, but I'm saying could it be made?
Absolutely, yeah, absolutely. You have got the option now, isn't it?
Yeah, yeah.
So I think it should change. It should go to class 3. Anyway, chalo.
Class 3 for what Shubhro wanted to tell you that TAVI used to be done in a high-risk patient. Now the indications is getting more flexible. Flexible indications.
Let's wait and watch. If after 5 years, 10 years, it is required, we can do a TAVI. You don't ask the surgeon to open the chest again. It's not needed.
You can do the TAVI even earlier than that, because that is the newer views of that disease. You can do it at a low risk group, Euro score less than 4 or Euro score just 4 to 6. You can do it. Previously, it was thought to be only done in a very high risk patient where general surgery.
No, the partner series has told us what are the indications.
That's why I say after the partner series treatment, now we are
partner 1, 2, 3, and all these things has told us enough regarding this particular aspect. So now it is fairly clear.
Yeah.
Papa, let us proceed. That is one question from Shuchit. What is the durability of the TAVR valve? TAVR valve is again a bioprosthetic valve.
Sir, I want to answer this question. So we have data up to 5 years regarding the TAVR valve. So up to 5 years, that there is no documented degeneration of the TAVR valve till now. So as more and more years will pass by, we will have further data regarding this TAVR valve. Oh.
But in this is a bioprosthetic valve, so the maximum durability it will have is like another bioprosthetic valve.
Yeah.
Okay, carry on.
Okay. Now coming to management of patients with rheumatic mitral stenosis. So as Soumitra sir was telling regarding the indexed area, both the guidelines have not used any indexed area. They have given the total area MVA less than 1.5 and MVA more than 1.5. So patients with severe AMS, that is MVA less than 1.5 centimeter square. If the patient is symptomatic, the valves are pliable, there is no clot, MRD is less than grade 2, straight away go for a mitral balloon commissuration.
Just one question. Is this 1.5 square centimeter absolute value or per square meter or per 1.73?
Absolute value, sir.
This is an absolute value.
Absolute value.
That's a bit ridiculous. Okay, chalo.
Sir, if this absolute value comes to a 1 centimeter square per body square surface of body per meter square of body surface area.
But that should have been written, na?
But that is not within the guidelines. They have.
I'm telling that, but you have to criticize the guideline.
Yeah,
guideline
that has been adequately criticized, but we won't be able to finish. But it's very valid question.
Yes,
very valid question.
Yes, sir.
But
yeah. So if the valve is not pliable, if there is presence of clot, if there is more than grade 2 MR, so in patients who are NYHA class 3 to class 4, in those patients you go for a mitral valve surgery. In these patients, DPR is preferred over valve replacement. If the patient is not a surgical candidate, in absence of clot, we can still go for a balloon commissurotomy, which is a class 2B indication, and it should be done at a comprehensive valve center. In asymptomatic patients, that is stage C patients, if the valve is pliable less than grade 2 MR, there are 2 additional indications by this ACC-AHA guideline. If the PASP is more than 50, or if there is a new onset AF, we can go for a balloon commissurotomy. If PASP is more than 50, it is a class 2A recommendation. If there is new onset AF, it is a class 2B recommendation. In patients with progressive MS, where the area is more than 1.5 centimeter square, but the patient has exertional symptoms, on stress test, there is hemodynamic significant MS with a mean gradient more than 10. In those patients, if the valve is pliable, no clot, less than grade 2 MR, we can go for a balloon commissurotomy, which is a class 2B indication. Here I want to stress the ESC guidelines, more or less similar to the ACC-AHA guideline, but they have not incorporated the PSP portion and the new onset AFib portion. Others remain same between these 2 guidelines. Now coming to non-rheumatic calcific MS, in patients with severe symptomatic MS, where the valve area is less than 1.5 centimeter square, and the MS is because of extensive mitral annular calcification, valve intervention may be considered only after discussion of the high procedural risk in these patients, because the balloon commissurotomy will not be feasible in most of these patients. Now coming to management of patients with mitral regurgitation, the mitral regurgitation is classified into 2 groups, primary MR and secondary MR. Initially, I will discuss the primary MR. In patients with primary MR who has a severe MR, there is symptoms of MR, regardless of the LV function, you will go for a mitral valve surgery. In patients who have a high prohibitive surgical risk, in those patients only, we can go for a transcatheter edge-to-edge mitral valve repair. In other patients where there is no symptomatic, but the patient is having severe MR, in those patients who are in stage C2, that is LVEF is less than 60% or end systolic diameter is more than 40 millimeter, there is a definitive indication for a mitral valve surgery is a class 1. In patients with degenerative mitral disease, the successful and durable repair is very much possible. Here, it is a class 1 recommendation for mitral valve surgery. On the other hand, in patients with rheumatic mitral valve disease, successful and durable repair, where it is possible, in those patients, mitral valve repair is a class 2B recommendation. Here, I want to stress important thing. In the previous guidelines, this end systolic diameter was more than 45 millimeter. it has come down to 40 millimeter in these recent guidelines. In patients who are having no symptoms and in stage C1, that is end systolic diameter is less than 40 and EF is more than 60%, only in those patients where extremely expected surgical mortality is less than 1% with more than 95% likelihood of successful and durable repair, in those patients only we can go for a mitral valve repair. In other patients where there is a progressive increase in LV size or decrease in LVEF, which has been documented over 3 studies, in those patients we can go for a mitral valve repair or replacement. This is basically, in short, the management of patients with primary MR. Now coming to, if I go by the ESC guideline, they are more or less similar, but the interesting thing is that they have added this point of new onset AF and systolic pulmonary pressure more than 50 here in management of primary MR patients. And they have omitted these points in the management of MS patients. Now coming to management of secondary MR, in patients with severe secondary MR who are undergoing CABG, mitral surgery is a class 2A recommendation. In other patients who are not undergoing CABG, if the EF is less than 50%, in those patients where the mitral valve anatomy is favorable, LVEF is between 20 to 50%, end systolic diameter is less than 70 and pulmonary pressure is less than 70. In those patients, it is a class 2A recommendation for transcatheter edge-to-edge mitral valve repair. It was basically 2B recommendation in the previous guidelines. It has come up to a class 2A recommendation. In other patients where the EF is more than 50%, in those patients, it is better to go for a GDMT and AFib management. Class 2B recommendation for mitral valve surgery is there, but most of these patients tend to remain on GDMT if in these patients where the EF is more than 50%. So the ESC guideline echoes more or less the similar findings. I am not discussing the details again, but I just like to stress that in ESC guideline also, in patients where the EF is less than 50%, severe MR, symptomatic, in those patients, transcatheter edge-to-edge mitral valve repair is preferred over mitral valve surgery. So before going to tricuspid valve disease, I will be happy to.
There is a question from Shuprotip.
Yes, sir.
When shall we consider mitral valve repair in rheumatic heart disease?
Yes, this mitral valve repair in rheumatic heart disease is to be decided by the comprehensive valve center. If they feel that a durable repair is possible in patients with mitral regurgitation, then only we can go for a mitral valve repair. In other patients where mitral valve repair is not possible as deemed by the comprehensive valve center, you go for a mitral valve replacement.
What are the points we should see to pick up those patients? Just what are the points in our day-to-day practice? Suppose there is a rheumatic MR.
Yeah.
And it is fairly moderate to severe MR. Now, what should be the points we should see before sending the patient for assessment of repair? That is my question in our day-to-day practice.
In our day-to-day practice, as such, there has been no criteria has been laid down regarding to choice of a patient for a repair or replacement. It has been categorically said in both the guidelines that the surgeon will decide whether they can do a comprehensive repair or not, because in patients with rheumatic mitral valve regurgitation, repair, good repair is a very difficult job. So if we are going for clinical judgment, we can come up with our own experiences. But if I go by the guidelines, this is what the guidelines has to say.
Do you like, Bappa, do you like to comment on a little bit on mitral valve clip of surgery for repair?
So mitral valve repair, mitral clip.
Yeah.
So
Anjanda.
Yes.
Before that, what Shuprotip was asking, that has some relevance.
Yes, sir.
That in rheumatic mitral regurgitation, what are the indications of repair? Actually, it is rather fairly discouraging. That's because we have the largest series from All India Institute by Sampath Kumar. There the results was not at all good. Initially, those who achieved a fair amount of competence, again they degenerated into gross mitral incompetence. So it is unless a surgeon is specifically trained in rheumatic repair, mitral repair, this is rather a very difficult surgery and a fruitless surgery rather. That's why not many people, they want to do repair in patients with rheumatic mitral regurgitation.
Shantanu, you used to taught us, and Dr. J.C. Ghosh also used to teach us that rheumatic mitral regurgitation can never occur alone without mitral stenosis.
Yeah, but that is one concept, but it is seen that although there may be a very mild amount of mitral stenosis, that is not hemodynamically significant. That is more than 2.5 centimeters square or more than 2 centimeters square orifice area. So that we need to consider as sole mitral regurgitation. That's what that part I am talking about.
Yeah.
And here it is, if there is a mechanical problem, say a cordy has been torn,
yes,
that occurs more with the other ischemic and others, there a surgical repair can be attempted.
Absolutely.
But if it is a overall rheumatic mitral regurgitation with a retracted valve and improper cooptation of the edges, it is very difficult to go ahead with a reparative surgery. Shubhratip, I think I answered your question.
Suppose I am getting a moderate to severe MR patients. Patient is fairly asymptomatic. So should we wait with medical management for these patients?
Yeah, but it is better to, that is one issue is you need to, unless the patient is symptomatic or there is early signs of LV dysfunction, that is another point you need to see. So these are the patients who should be kept on medical treatment and watched closely with, say, every 6 monthly or yearly echocardiography, whether they are progressing, whether there is any early onset of LV dysfunction. In that case, early surgical interference is in order.
Does it prevent atrial fibrillation first episode?
Very difficult to say. There is hardly any data on this. I cannot say.
But most of our surgeons did not like to go for mitral valve repair in the time when we had a lot of mitral stenosis or mitral regurgitation cases. But there is no denying the fact, if the patient has rheumatic mitral regurgitation, having increased left ventricular end-diastolic pressure because of MR, these are the patients who get the maximum benefit. You repair the mitral valve, you reduce the left ventricular size, you reduce the left atrial size, and finally you reduce the hemodynamics of MR. And that goes a long way in saving the patients from complication of mitral valve disease.
A lot of mitral valve repair was done at medical college by Dr. B.N. Guhorai. He also had a long series, but I happened to be in the OT in some of his patients. What I found that they used to put some stitches on the edges to reduce the mitral annulus. Usually, and without any carpenter's ring or anything. Most of them had a significant residual mitral regurgitation. That is what we observed, and that is the observation in the Sampath Kumar series as well. Papa, proceed.
Sure. So now coming to management of patients with tricuspid valve disease. So a patient comes to us with tricuspid regurgitation. So he has severe TR. So either he is symptomatic or asymptomatic, that is stage C or stage D. Or the patient has a progressive TR, which is stage B. In those patients who are undergoing left-sided valve surgery, if the patient is having severe TR, so it is a class 1 recommendation to go for tricuspid valve surgery. In patients with progressive TR, that is moderate TR, at the time of left-sided valve surgery, if the annular dilation is more than 4 centimeters, or there is history of prior right heart failure, there is class 2A recommendation called tricuspid valve surgery. In other patients who are not undergoing left-sided valve surgery, the patient is symptomatic, that is stage D. In these patients, for primary or secondary TR, we can go for a tricuspid valve surgery. In patients who had a prior left-sided valve surgery, in symptomatic patients with severe TR and history of right heart failure, if there is absence of pulmonary hypertension or RBCD dysfunction, in those patients, there is class 2B recommendation for tricuspid valve surgery. In asymptomatic patients who have severe TR, in patients, if there is severe primary TR, in patients with progressive RV dilatation or systolic dysfunction, we can go for tricuspid valve surgery. This is in short the tricuspid regurgitation management by the ACC-AHA guideline. Similar is the findings for similar is the recommendation by the ESC guideline. They are divided into grossly between a need for left-sided valve surgery and not. If the patient has a need for left-sided valve surgery, the recommendation is similar to the ACC-AHA guideline. Severe primary TR, you go for tricuspid DPR or replacement. In mild to moderate TR, if there is tricuspid annular dilatation, in those patients only you go for tricuspid DPR or replacement. In other patients where there is no need to go for tricuspid left-sided valve surgery, in those patients with severe primary TR, if the patient is symptomatic, you go for tricuspid valve repair. In other patients where there is severe secondary TR, if the patient has not developed severe RV or LV dysfunction or severe pulmonary hypertension, in those symptomatic patients, you go for a heart team evaluation for a tricuspid repair or replacement. In other patients with severe secondary TR who has already developed a severe RV or LV dysfunction with severe pulmonary hypertension, in those patients, it is prudent to go for a medical management. More or less similar recommendation by the ESC and the ACC-AHA guideline. So may I proceed with the prosthetic valve?
Yes, please.
Yeah. Now coming to the prosthetic valve requirement. So it is a shared decision making regarding the choice of a prosthetic valve in patients where there is contraindication for VK anticoagulation or VK anticoagulation cannot be managed or not desired. In those patients, you go for a bioprosthetic valve. In other patients where the VK is okay, if the patient is undergoing an aortic valve replacement less than 50 years, a mechanical AVR is the choice. Between 50 to 65 years, you can choose between a mechanical or bioprosthetic AVR. For more than 65 years, you choose a bioprosthetic AVR. For mitral valve replacement, where repair is not possible, particularly in rheumatic patients, less than 65 years, you go for a mechanical MVR. More than 65 years, you go for a bioprosthetic MVR. Now, regarding this anticoagulation in patients with mechanical valves, a mechanical AVR with no risk factors, INR goal is 2.5. If antiplatelet therapy is indicated for any other reasons, you add a aspirin in a dose of 75 to 100 milligrams. In these patients, if VK therapy is interrupted for any non-cardiac procedure to minimize time with subtherapeutic INR is recommended, no bridging is required. In patients with mechanical AVR with other risk factors or with a history of prior thromboembolic event, in those patients, INR goal is 3 as with mechanical MVR. In these patients also, routine aspirin is not recommended. If antiplatelet therapy is indicated for any other reason, in those patients add aspirin in 75 to 100 milligram dose. But these patients require bridging anticoagulation when INR is subtherapeutic during any other non-cardiac procedures. For bioprosthetic valve, we have discussed this thing in my previous slide. For the surgical bioprosthetic AVR or MVR, initial 3 to 6 months, if the patient has developed a AFib as per the ACC-AHA guideline, a VK anticoagulation with INR goal of 2.5 is recommended and lifelong aspirin is recommended. For TAVI patients, in the initial 3 to 6 months, you go for aspirin plus clopidogrel or a VK anticoagulation INR 2.5. Then after 3 months, you go for a lifelong aspirin. This is the ESC recommendation. This I have discussed in our initial discussion. Now, patient with a prosthetic valve develops a thromboembolic event. For an aortic mechanical valve with INR in range, increase the INR to 3 or add aspirin. For a mitral mechanical valve with INR in range, you increase the INR to 4 or add aspirin. For bioprosthetic AVR or MVR on antiplatelet treatment, you add a VK anticoagulation instead of antiplatelet treatment. In suspected mechanical valve thrombosis, you go for a TTE, TE or CT imaging. There is left-sided mechanical obstruction, you go for urgent emergency surgery. If not possible, slow infusion of fibrinolytic agent is recommended. For suspected bioprosthetic valve thrombosis, you start with treatment with a VKA. Now, patient with prosthetic valve who has a suspected valve stenosis. In this patient, after diagnosis with a TE or for the CT, if the patient is having severe symptomatic stenosis, for mechanical valve, surgical intervention is the recommendation. For bioprosthetic valve, there are 2 choices. For patients with a low prohibitive surgical risk, you go for surgical intervention. For high surgical prohibitive risk, you go for a transcatheter valve-in-valve intervention. or suspected mitral valve for posterior valve regurgitation, if the patient has developed intractable hemolysis or heart failure without high surgical probability risk, you go for a surgical intervention. In other patients, if it is a paravalvular regurgitation where there is probability risk is high, you go for a percutaneous repair at a comprehensive valve center. For bioprosthetic valve regurgitation, you go for a transcatheter valve in valve treatment. For asymptomatic patients with severe regurgitation, surgical intervention can be done when there is low surgical risk. This is the more or less similar between the ESC guideline and the ACC-HA guideline. I am not discussing in details again this guideline, but the more or less they echoes the similar recommendation as per the ACC-HA guideline. Regarding infective endocarditis, there are no as such new recommendations. Just a few things I want to stress. For patients with valvular heart disease with unexplained fever, should not receive antibiotics without blood cultures. In patients who have a definitive infective endocarditis with implanted cardiac electronic devices, complete removal of leads and generator is recommended. For patients with posterior valve endocarditis with relapsing in infection, you go for surgery. There is no role of conservative management. Recurrent endocarditis with continued IV drug use, you go for a about long-term prognosis should be discussed before going for a surgical intervention. For patients with recurrent emboli or persistent filtrations despite antibiotic treatment, early surgery is the recommendation. In patients where there is a more than 10 mm filtration, you go for an early surgery. Only thing is that if a patient with infective endocarditis has developed a ischemic stroke or intracranial hemorrhage, we should wait for 4 weeks before going for a surgical intervention. Now coming to the another interesting thing, pregnancy and valvular heart disease. There will be a lot of debate regarding these portions, so I am discussing these things quickly. All women with suspected valve disease who are considering pregnancy should undergo a clinical evaluation and TTE before pregnancy. So if the patient is having symptoms, it should be intervened before pregnancy. If the patient is not having any symptoms, exercise testing is reasonable. If there are provoked symptoms, you go for intervention. A patient with severe rheumatic stenosis, mitral stenosis amenable to balloon commissurotomy, go for a balloon commissurotomy before pregnancy. Severe aortic stenosis, valve intervention before pregnancy is reasonable. After going for a shared decision making, we can go for a bioprosthetic valve versus a mechanical valve. In patients with severe MR and valve repair is suitable, a valve repair should be considered before pregnancy. Now, this most interesting thing. So a patient with a mechanical valve or a bioprosthetic valve who has become pregnant. So pregnant women with mechanical prosthesis should receive therapeutic anticoagulation with frequent monitoring during pregnancy. So can the patient maintain therapeutic anticoagulation with frequent monitoring? If the answer is no, counsel against continuation of pregnancy. If the answer is yes, we have to look what the warfarin dose he is getting for a maintenance of a therapeutic INR. If the warfarin dose is less than 5 mg, we can continue warfarin for all 3 trimesters after thorough risk discussion, or we will go for a dose-adjusted low molecular heparin for the first trimester, followed by warfarin for second and third trimester. If the warfarin dose is more than 5 mg per day, in those patients, we will go for a dose-adjusted LMWH for the first trimester, followed by warfarin or second and third trimester, or dose-adjusted LMWH for all 3 trimesters. Or if dose-adjusted LMWH with monitoring of anti-factor with 10A levels is not available, you go for continuous dose-adjusted unfractionated heparin to maintain APTT of the at the range of 2 times that of normal, followed by warfarin in the second and third trimester. At least 1 week before delivery, discontinue warfarin, switch to continuous unfractionated heparin or dose-adjusted LMWH. At least 36 hours before delivery, switch to unfractionated heparin. Stop heparin 4 to 6 hours before planned delivery. If labor begins or urgent delivery is required in a patient therapeutic anticoagulated with a VKA, go for a 4-factor platelet prothrombin concentrate before cesarean section should be done. Now some miscellaneous facts. So patient undergoing valve intervention, as Anjanlal sir was discussing. So in these patients who are planned to go for a TAVI with a low risk of CAD, you go for a coronary CT angiogram. With high risk of CAD, go for a routine coronary angiogram. Patient has a left main or proximal CAD, PCI should be done prior to TAVI. Patient has a complex bifurcation left main lesion or a multiple CAD with a syntax code of 33, you go for a surgical AVR and a CABG. For patients with low to intermediate risk, you can go for a CT coronary angiogram. For patients with high risk of CAD or chronic severe MR, you go for a coronary angiogram and decide after the clinical decision making regarding the valve surgery or TAVI should be done after the coronary angiogram reports are available. Now, this is another thing that has been updated recommendation. So a patient with surgical valve intervention who has a AF, if the patient, there should be risk benefit and discussion regarding the other adjunctive AF procedure. LA appendage ligation or excision now has a class 2A recommendation, which has upgraded from class 2B, and surgical pulmonary vein isolation or mesh procedure is also a class 2A recommendation. Anticoagulation therapy should be done at least 3 months after the procedure. In the earlier recommendation, it was a class 2B recommendation for a LA appendage ligation or excision, which has upgraded recommendation in this recent guideline. Now, most of our elderly patients who have AS may require urgent or elective non-cardiac surgery. In these patients, where there is a urgent non-cardiac surgery and the risk of NCS non-cardiac surgery is very high, we may consider for a BAV before doing NCS if it is doable in patients with severe AS. In patients where the risk of NCS is low to moderate, we can go directly for the NCS with strict monitoring of the patient. In elective patients, if the patient has symptoms of aortic stenosis, patient risk for AV procedure is low, you go for heart team decision for a SAVR or AVI, then go for the non-cardiac surgery. In patients where there is no symptoms and the risk of NCS is high, in those patients also, you heart team discussion regarding the aortic valve surgery before the procedure should be discussed. Where we are not going for a TAVI or SAVR before the non-cardiac surgery, in non-coronary surgery can be done under strict monitoring. So I have tried to cover the most important aspects from the 2 guidelines. So now we can be having any other questions if there are. Thank you.
To elaborate, to discuss, we won't be able to finish. Just a quick comment from Dr. Guha and Shubhro Anjanda that as you said, mechanical mitral valve in aortic place, INR range, INR is 2.5. And then in mitral valve 3. Actually, traditional teaching and more pragmatic is to give a range. 2.5 to 3.5 for aortic valve and 3 to 4 or 4.5 to mitral valve. You cannot have a single figure.
2 to 3 to 2.5 to 3.5.
Yeah, yes.
2.5 to 3.5 of aortic.
No, 2.5 to 3.5 for mitral or DVR, and 2 to 3 for aortic. Aortic, we require a lower INR.
Yeah, lower.
They have taken the mean INR for this.
I have just one small comment to make, which goes in like what Dr. Shantanu Go told us. Surgery, artificial mechanical valve in the aortic valve region and a mitral mechanical valve has 2 different outcomes so far as embolism or prosthetic is concerned, thrombosis is concerned. Because aortic valve is in the range of high flow blood. So the incidence of aortic valve thrombosis or thrombosis related to aortic valve is comparatively less than mitral valve. Mitral valve is there in a low flow blood channel. Therefore, the incidence of mitral stenosis giving rise to ischemic or prosthetic stenosis is very high. Unless you take care of the anticoagulation properly.
Bappa, thank you very much. It's a very exhaustive thing. It is a very exhaustive thing. I think we should have segregated it into 2 or 3, divided into 2 or 3 parts and then discuss. Things would have been better. This is a very long subject to be discussed in a one go. But anyway, you have touched upon all the points and thank you very much. And
so
if you go
from now onwards, Bappa, you can just split it here and there and give us independent lecture on that particular subject.
So thank you, sir. Thank you, sir.
Okay, thank you, Bappa. So next speaker is Meeta. She will be speaking on a case of an atypical chest pain. Meeta, you are here?
Sir, yes, sir.
Please start sharing your screen. We are already late. So your case is a small one, as you say. So we'll finish on time.
Sir, is my screen visible?
Yeah, it's visible.
Good afternoon, my respected teachers, my seniors and colleagues. My case is a case of atypical chest pain. My patient, a 59-year-old female patient, diabetic patient, normotensive, came to our OPD Medical College Hospital. We admit this patient with, there was a chief complaint of chest pain for 2 to 3 years. The chest pain was not, there was no definite relation with exertion. There was the character of the chest pain was atypical in nature. There was no history of palpitation, no syncope. There was no significant past history, and there was no significant family history. On general examination, her vitals, pulse was 76 per minute, regular, normal volume, no radioradial or radiofemoral delay. There was no spacious character. Blood pressure was 136 by 78 mm of mercury in right arm. Pallor, cyanosis, clubbing, icterus was absent. GBP was not raised and pedal edema was absent. On cardiovascular system examination, inspection, palpation, and auscultation was within normal limit, and there was no murmur on auscultation. On examination, investigation, this was the ECG of this patient. From the ECG, there was a sign, patient was in sinus rhythm, there was left axis deviation, and there was poor progression of R wave in precordial lead. And echocardiography was done. There was left ventricular ejection fraction was around 58%. There was no RWMA at rest. There was normal RV function. There was grade 2 MR and mild TR, apical fourth chamber view, and there LV was mildly dilated. Next, we proceed and there on parasternal short axis view, we found that there was a dilatation of the right coronary artery ostium around 10 millimeter, and there was a color on color Doppler study. There was a color flow from pulmonary artery to aorta. This was the angiography of this patient. During left-sided angiography with GL catheter, there was no coronary, left-sided coronary artery visible on coronary sinus short. On the right side, there was a hugely dilated tortuous right coronary artery, and it supplied collateral to the left system. This is another view, epicranial view. There is a hugely dilated and tortuous right coronary artery supplying collateral to the left system, and this is the collateral supply. So, my case was, it's a case of anomalous left coronary artery arising from pulmonary artery. In this case, the unique features in my case was the Al Kappa with a late presentation. The age of my patient is 59 years. Usually Al Kappa present in an early age group. 90% of patients present in first years of life, and usually if untreated, there is a risk of death, heart failure, and risk of death within 1 year of life. But in my patient, the patient was usually asymptomatic till her adulthood, and the patient is presenting at age of 59 years. And on clinical examination, there was also there was no significant murmur on auscultation. There are some few case reports which shows that in a late presentation, it was Al Kappa was incidentally detected during examination findings with the features of continuous murmur. But in our case, there was no such findings, and there are also some case report with very late presentation of Al Kappa incidentally, which was incidentally detected. So, on my case is a case of Al Kappa at the age of with delayed presentation. Thank you, sir.
What is the cause of chest pain?
Sir, Probably the patient actually said chest pain was atypical in nature. Actually, it occurred, according to the patient, it occurred even at rest intermittent and also may mildly increase during exertion. Probably demand supply mismatch may be the reason, though there was huge collateral. But there may be some possibilities of demand supply considering this age increasing the demand and LV dysfunction. This though the ejection fraction was around 58%.
You could
get Mita, unshare the screen.
Yes, sir. Yes, sir. Yes, sir.
You could try to get into the left coronary artery either through a pulmonary artery angiography, or you could go for a CT coronary angio and to identify exactly from where the left side has come up and whether there is any disturbance in the flow pattern to explain chest pain.
Actually, sir, CT coronary angiography was done, but there was no significant abnormality in the considering the flow from pulmonary artery to left system. CT coronary was done after coronary invasive coronary angiography.
It is several places. There are several reports of getting it in the adults. In fact, the first case of Al-Kappa was in a patient, 59 years old lady. So this is not rare, but we see more and more cases in the infancy and in the neonates and in the early childhood, where the presentation is with failure. Mostly the presentation is with failure because the child is unable to say about the chest pain at that point of time. Majority, they do not survive the first few years in life, but there are reports that many patients, even they survive up to 90 years, that is one report. So she thought it is what's presenting that we do also get some cases of atypical chest pain where that is actually an Al-Kappa. Any comments? Chaumitra?
Really? I thought it sounds quite similar to a South American animal. It's as foreign to me. I haven't seen an Al-Kappa. I have read it. I haven't seen Al-Kappa.
Oh,
how frequently have you got it in your career, Shantananda?
We saw quite a few.
Quite a few?
Yeah. When we were in SSK, we saw quite a few cases. And Al-Kappa,
is it again a government hospital-oriented disease?
It is found mostly in children, which, you don't see them in your clinical practice. That is the thing. And we get the referrals from the pediatric wards mostly.
True.
So that's why you may not have seen these patients very often. But
yes,
we see it say once in a year or two. That is there. Yeah. That is fairly rare. But
as a case presentation,
we do get these cases.
The only thing is, what is the outcome of this?
Outcome, a person surviving up to 62 or what was the age?
59 years, sir.
59. Perhaps unless and until the patient has a very severe chest pain, nothing is required. And in fact, we didn't do anything.
In fact, you are absolutely right. That most of the Al-Kappa patients have symptoms and serious effect of the cardiovascular system by the age of 30 years.
Yeah, it's early, quite early. Maximum infancy and early.
If the patient has survived well up to this age, I think
nothing happens. Nothing happens.
Unless there is any serious complication, don't do
anything. Any genetic predisposition?
It is a developmental problem that
mutation, not genetic. Any other associated congenital disease, Mita?
Yes, sir. There may be presence of patent ductus arteriosus associated with L-kappa, and there may be some mitral valve prolapse, and also maybe mainly is a patent ductus arteriosus.
Is there any incidence of pulmonary hypertension?
Yes, sir. There is. It depends upon the collateral supply. As there is left to right shunt, there is chance of development of pulmonary arterial hypertension, and but pulmonary arterial development of pulmonary arterial hypertension, it is also it can be helpful for the patient also.
Yes, is corrected.
Yes, sir. Actually, with the development of pulmonary hypertension, there is less chance of shunting from left side to right side. So it may be helpful for the patient also, and for the delayed presentation. Yes, sir. For the delayed presentation, actually, the presentation age of presentation actually depends upon the collateral supply and also the pulmonary artery hypertension. So both can contribute for the symptom and the age of presentation. But most of the 90% of the patient usually present within 1 year of life, and without treatment usually they can die, and at the age of 35 years there is risk of sudden death without any treatment. There is a chance of sudden cardiac death and arrhythmia is high without treatment, but at the asymptomatic patient in such a late presentation is usually rare.
So Shantanu, in your case, Shantanu, did you come see your right coronary artery so large and wide?
Yeah, it's very large in this case.
The other cases that you saw in your hospital, were there the RC like this?
It all depends on which coronary artery is arising from the pulmonary artery.
Yeah.
It is we say L-kappa is original left from the pulmonary artery.
Yes.
It can be the right also.
The reason is, I tell you,
it can be right also, right arising from pulmonary artery and LAD.
What I want to say is that the patient is not too much symptomatic because of the fact that right coronary artery is so large and wide, and the supply that left side receives through pulmonary artery
was adequate, was fairly adequate. Yeah, in fact, these are the cases. Whether both the sinuses are from the aorta, or one from aorta, one from the pulmonary artery, and from the pulmonary artery either can arise. It can be commonly it is left, sometimes it is right. So this is the usual issue. The babies, they usually come with failure. They come with failure, that is their presentation, yes. And after some time, yes. You get a very prominent murmur. Often you miss this continuous murmur. That can be continuous murmur, absolutely. But often you miss that thing. But what you get is a mitral regurgitation murmur. And AMR murmur is the most prominent murmur what we get sometimes in the sick children.
Okay, that is a good case. From time to time, it just...
There should be some variation.
Revises from a,
There should be some variation from coronaries to non-coronaries and others. So we welcome this type of cases as well.
Yes, these are
a very good case.
Thank you, sir.
Thank you.
Thank you. Thank you. Had a very exhaustive discussion on valvular heart disease, which is I would rather say it requires a repetition. After some weeks, it requires a repetition.
A repetition, but in each session we'll have one coronary artery.
Honestly.
One valve.
Honestly.
So we had a good discussion, and we had a very interesting and rather rare case of L-kappa in an adult rather than elderly. So let us call it a day, and we'll meet again after 2 weeks on Sunday morning.
Supradeep, what is that animal called in South America? Is it alpaca, isn't it? Supradeep?
South Africa.
It's called alpaca. It's L-kappa, and that is animal is called alpaca. Chalo. Okay.
Chalo. Okay. Bye-bye.
Thank you, sir.